Our goal is to tell you not only what to do and when to do it, but also to tell you why we do what we do. And this first lecture that I'm going to be giving is talking about some of the literature review. And it's not that we want you to be academicians when it comes to diabetes, but I think it's important to know why, because what if a patient asks you, well, doctor, why should my A1C be such and such, or why should my blood pressure be this? I seem to feel just fine with my blood pressure being 170. Do I really need to lower it? And you'll be armed with information that will say, well, you know what, Miss Jones, whenever we lowered that blood pressure down by 10 points, we reduce a person's chance of dying by a third. That'll get people's attention, and we're going to give you that kind of information today so that you can answer those kinds of questions. Several things that we're going to do. We're going to try to make this as evidence-based as possible. Obviously, sometimes there's not great evidence, and when that's the case, we'll give you more expert opinion. Some of the things with the financial incentives that are attached to it will allow you to become an agent of change. And so hopefully it'll allow you to impact your program so that you can go back and actually improve the care of your diabetic patients wherever you practice. And I will say this, if you're in residency, which I know most of you are in a residency, or you're a faculty in a residency, you have probably the hardest patients in the world to treat. For 10 years, I was in academics as a faculty in a family medicine program, and our patient population in the program where I was just incredibly sick, and I'm sure yours is similar. They tend to be poor, have lots of comorbidities, and so it's a very challenging patient population to treat. I've been in private practice now for about 5 months, and although some of that's changed, there's still similarities. We're also going to have a diabetes educator talk to you, and I know within this room there are people who are not clinicians, but have some role, whether it's as a nurse, a medical assistant, or a diabetes educator, that are going to be helping you as an agent of change. And we'll be having a breakout session for those individuals as well with our diabetes educator. And we're going to give you some tools that will help you affect change in your practice. Okay, this is data from the Behavioral Risk Factor Surveillance System, which is given by the CDC. And this shows the prevalence of diabetes and gestational diabetes. And this is historical data. This was what diabetes was in 1990 as far as prevalence. You can see the states that are in red, it was above 6%. How Oklahoma was 4 to 6, I do not know. And then some states there wasn't any data. Now several things changed since then. The definition or the diagnostic parameters for diabetes changed. About 10 to 15 years ago, it used to be a fasting blood sugar of 140. If you were above that, that was considered diagnostic, and now it's if you have fasting blood sugars above 125. And so there was a change in the threshold for diagnosing somebody. But there's also been an increase in the prevalence, just simply because of obesity that we see in the United States. So that's 1990. This is 2000, once again using the same surveillance system. And California says is above 6%. I looked last night at California's data, and it looked to me like it was, depending on who you ask, but around 8% right now is what it is in California. Probably in your patient population, it might be higher than that if you are in a residency setting. And then this was what's been projected. This isn't actually data that we know is completely accurate, but it estimates that the prevalence, dark red, is above 10% across the entire United States. That's probably a little bit of an overestimate. Like I said, California is more about 8% right now. Oklahoma's in the 9% range, and other states, particularly if you live in the southeast, there's a higher prevalence. It also depends on the ethnicity of your state as well. Hispanic Americans have a lot higher prevalence than Anglo-Americans, and African Americans have a lot higher prevalence as well. So it just depends on the makeup of your patient population too. But nonetheless, I think it's easy to say that the prevalence has escalated significantly and that there is indeed an epidemic of diabetes, particularly type 2 diabetes. Here's some other facts. It's the 6th leading cause of death in the United States and the most common cause of blindness, end-stage renal disease, and amputations, and it's a major contributor to cardiovascular disease. The JNC7 gave diabetes a coronary equivalent risk. So even if you have a diabetic who's never had a heart attack, their risk is similar to somebody who has had a heart attack in trying to predict future cardiovascular events. The financial cost is huge. The average type 2 diabetic who's had a heart attack is going to spend $40,000 of healthcare dollars, heart failure, and this is on an annual basis. Renal disease, and this doesn't include end-stage renal disease, but it's much higher than that, obviously, if you have somebody on dialysis. So it's expensive. I'm going to move and just review some of the literature, and some of this hopefully is old news to you, but it may not be. For a long time, the question of does glycemic control matter was not clearly known. There were some people who thought it did, and some people who really didn't think it made a difference at all. Back in 1993, there was a study published in the New England Journal of Medicine called the DCCT, or Diabetes Complication Control Trial. This was a study done on type 1 diabetics. And I'm a type 1 diabetic. I was diagnosed at age 12. And so this is something that I was always aware of growing up and kind of motivated me to try to take control. But you can see what this study was, about 1,500 type 1 diabetics. And they divided the group into two groups, a group that was tightly controlled, and by tightly controlled, they took multiple daily injections, or they were on an insulin pump, or they took 1 or 2 injections a day. And then they separated out the groups. And the people who were intensively treated had A1Cs of about 7. The people who were less intensively treated had A1Cs of about 9, and followed them over several years. And here over about a decade, you could see the separation. And what was clearly shown from the DCCT was that microvascular disease went down substantially. This shows the effects of tighter control on eye disease. Retinopathy was down substantially in people who had tighter control. Remember, the average A1C of the people in the red group was about 7. The people in the blue group there was about 9. Similar things were seen with kidney disease, really almost an identical separation with kidney disease as well. And by the way, I will tell you that if your slides don't follow exactly, don't just pay attention to what's being shown up there, because there may be a few alterations, but just hang in there, and eventually they'll look similar. What was not shown in the DCCT was there any benefit with heart disease? And after the DCCT concluded, after that 9-year time frame, they said, okay, enough's enough. We're going to treat everybody intensively, because it's clearly shown that these people do better when they're managed more tightly. And once they did that, they treated everybody with multiple daily injections or insulin pump therapy, and followed them for another 10 years. And this was called the EDIC trial. I actually, as I said, I went into private practice about 5 months ago, and I have a patient who was in the DCCT and is in the EDIC trial. And so he was telling me, because, yeah, I was a part of this study back in the 90s, and I said, you were in the DCCT? He goes, yeah. I'm like, oh, wow. It was so cool. So anyway, but it was just cool to finally meet a patient. I mean, out of 1,441, I have one of them. But what was shown is that even though after the DCCT ended and it moved on to the EDIC, and that stands for Epidemiology of Diabetes and Complications, these people, their A1Cs, instead of having that big separation between 9 and 7, they actually kind of merged, and it went closer to probably what's more reality. They had A1Cs probably in the high 7s or even 8% range, okay? All these people were on insulin pumps or multiple daily injections, and then they followed them. The people who in the DCCT were treated more intensively had a 42% reduction in macrovascular events, so fewer strokes, fewer heart attacks. And so it really kind of perplexed people. They're like, these things didn't happen when we were managing them intensively in the DCCT, and so it led to a realization that there is some kind of a legacy effect with glycemic control. And so as people are treated tightly, so when you're thinking about that patient who's 35 years old and you're trying to maintain an A1C of around 7, remember what you're doing. You're affecting their outcome for decades, okay? And that's something that's been shown from that study.